Okay, try that again. Good morning, everybody, and welcome to Medical Grand Rounds. Today is our latest edition of the summer series, and we shift into the topic area of infectious diseases, and we are very fortunate to have two speakers today. So first up will be Dr. Sophie Woolston, who is a graduate of Wesleyan University. She went to medical school at University of Pennsylvania, did her internal medicine residency at Penn, also in Philadelphia, and then her infectious disease fellowship in Seattle at the University of Washington. And she joined Maine Medical Partners Infectious Diseases in 2019. And then our second speaker will be Dr. Emily Wood, who is a graduate of Bowdoin College, Tufts University School of Medicine. She did her internal medicine residency, chief year, and infectious disease fellowship here at Maine Medical Center. And she has been the program director for the infectious disease fellowships for many years. I actually forgot how many, but it's only 5? Seems like longer, yeah. And so they're going to be speaking on a good summertime topic, which is infectious disease emergencies. So first up is Dr. Woolston.
Thanks, everybody, for having me. I certainly enjoy this topic, and Dr. Wood and I decided to essentially share this topic, and so I'm going to be speaking on a couple syndromes that in particular I enjoy managing, and so we'll get right into this. Here we go. I have no disclosures to report. So I wanted to just spend about one slide just defining some infectious disease emergencies, and then start the discussion reviewing toxic shock syndrome, necrotizing soft tissue infection, and deep neck space infections as well. And I chose these topics in particular. I enjoy the management of these three, and they share, to me, the overlap of a rapidly progressive infection that I think in particular I'm passionate about the multidisciplinary practice of medicine. So all three of these usually are those that are co-managed by infectious disease, usually critical care physicians and surgeons as well. So some ID emergencies, and I wanted just to lay this out because I think often infectious disease consultants are thought to be slow, deliberative, provide slow and deliberative advice for patients in the hospital. And there certainly are some syndromes which require our immediate response to help you and our surgical colleagues out. So some include clinically resistant neutropenic sepsis, spinal epidural abscesses. I included antibiotic selection for multi-drug resistant ventilator-associated pneumonias in the critically ill patients, as well as any diagnostic guidance for analysis of tissue or fluid that's hard to get, particularly in critically ill patients. Clearance for emergently needed transplant or deep space device placement, how to operate our lives during a pandemic, which seems like one long emergency, and then some of the other syndromes that myself and Dr. Wood will describe today. So first up, I wanted to start with, and I'll spend the most of the time talking about toxic shock syndrome. And this to me is sort of the boilerplate for also talking about the other two syndromes as well. So this is described as a severe multi-system disease caused by the body's sort of over-exuberant response to toxins created by bacteria. Generally, there are the sort of overlapping syndrome includes fever, hypotension, skin rash, and multi-organ system failure that often can include the gastrointestinal system, musculoskeletal, kidney, liver, CNS, and mucous membranes as well. Mortality rate is high, which also to me makes this a very interesting topic, 5 to 10%, but actually much higher with some microorganisms as well. Most of the time, this is caused by either Streptococcus pyogenes, which I'll refer to the syndrome as Group A strep toxic shock syndrome, or Staph aureus as well. And then there are other microorganisms, which I'll get into one as an example. Generally, what happens is certain bacteria of the above species will produce a toxin. This creates super antigen and massive cytokine production in the body. The toxins we most often think of with Staph aureus, toxic shock syndrome, TSST, and this has been generally identified in 100% of cases that are associated with menstruation, less often in those cases which are not associated with menstruation. as well as other enterotoxins as well. And the thought is that likely this is not as simple as we once realized, that there probably are, as in most cases, several signals and several toxins working together. In Group A strep, this is also not necessarily one toxin in particular, but we most commonly think of hemolytic toxins, either streptolysin O or streptolysin F, as well as M proteins as well. I found the historical context of toxic shock to be really interesting, and I probably spent too much time in the physician's lounge reading about the sort of the story of toxic shock, particularly in the 80s. And I think I was interested in this as a child growing up in the 1980s. This to me was something that kind of haunted a lot of discussions around the dinner table at night. Toxic shock was first described in 1978. It was first described in children, but it really became part of the public imagination, sort of, I would say, terror, so to speak, in 1980 when it was described as related to tampon use. In 1980, 35 healthy women died in 890 cases of Staph aureus toxic shock syndrome. And I just found sort of the history of this outbreak, so to speak, very interesting as someone who really enjoys understanding how infections and sort of social response interact. I just found this to be interesting. So in January of this year, of 1980, a state epidemiologist notified the CDC, having observed 9 cases in Minnesota and Wisconsin. The CDC responded by creating a case definition, creating measures for passive surveillance, and published an MMWR article. And this sort of precipitates this mass hysteria in the public about what exactly the risk factor is preying upon young, healthy women. There became a recognized association with menstruation, tampon use, and then specifically this one type of tampons, and I just added this photograph from a Rely tampon commercial. In the end, of course, there is no specific association with that particular brand, just the degree of high absorbency of tampons that were possibly available in the 1980s. And again, I just thought it was really interesting to review how a public health crisis, which was affecting and infecting people, how they had to answer squeamish topics about the thorny topic of menstruation, and really how sort of reluctance to discuss this normal and natural topic may have impacted and possibly delayed how it was being addressed. The peak incidence actually occurred this year as well, and it was, of course, associated with vaginal tampon use in menstruating women. The CDC has gone on to report fewer cases as the years go on, with decreasing incidence of Staph aureus toxic shock syndrome and increased incidence of Group A strep toxic shock syndrome, likely since high absorbency tampons have been removed from the market. Group A strep is first described in 1987, and it's important to note it has a much higher mortality rate than Staph aureus toxic shock syndrome. So Group A strep toxic shock, there was a working group that defined this in the following way. Generally, patients experience hypotension and then 2 or more of the following organ involvement. So acute renal failure, coagulopathy, liver failure, ARDS. And then often the hallmark is, which occurs most but not all the time, skin manifestations of generalized erythroderma with desquamation, which we can see here in the picture, as well as localized cellulitis with vesiculation or bullae formation. And again, it's often this rapid progression of that. Soft tissue necrosis, and is often associated with vascular compromise, which may be the explanation for its high mortality rate. In general, this sort of presentation, from sort of onset of presentation to shock, this can occur over a 1 to 3 day period. And notably, as I alluded to a moment ago, about 20% of the cases will not have soft tissue involvement. So there is some diversity in the clinical presentation. Interestingly, about 60% of the time, blood cultures are positive for Group A strep. And I just found it interesting that kind of the typical patient is someone who is about 50 years or older, not necessarily immunosuppressed. And this occurs about 3.5 per 100,000 persons and is quite fatal if diagnosed. The risk factors for group A strep toxic shock syndrome, trauma plus HIV infection, IV drug use, poor hygiene, being postpartum, patients who are obese, peripheral vascular disease, and then often kind of risk factors for some degree of immune dysregulation, diabetes, steroid, or malignancy. The use of NSAIDs has been noted, and it's unclear if NSAIDs really are a risk factor for this syndrome or more likely a risk factor for severe disease. You guys, of course, are probably aware of this concern of NSAID use in the response to infection with COVID. And the sense is that there may be a similar concern that NSAIDs may suppress our own body's ability to react to toxin production. Generally, we treat shock. Surgery is key here, so the debridement of necrotic tissue both assists in diagnosis and exploration, and early source control clearly saves lives in this syndrome. Dr. Wood was asking me last week if I was going to include any gory pictures, so I went back and added several. But I mostly, particularly for us in internal medicine, who often aren't invited to the operating room, I think it's really interesting to really understand, obviously, what they're seeing in the operating room. So obviously on the left is sort of this bullae formation that I was discussing. And then on the right, I think they're obviously revealing the fascial plane with cloudy fluid there as well. And typically surgeons must be more aggressive with exploration than not, so to speak, than being more conservative to ensure that they have achieved source control. So antibiotic-wise, I also found this to be really interesting, and hopefully I can communicate sort of the importance of actually not using penicillin in this case. Often we think about strep and sort of the happiness with being able to use such a narrow antibiotic such as penicillin. But this is actually one time in which beta-lactam agents over penicillin seem to actually treat this infection better. And the thought is that beta-lactam agents kill more rapidly growing bacteria. So at the beginning of this shock period, these are more effective than actually the use of more narrow penicillin. And in addition, beta-lactam agents provide anaerobic coverage. And the third reason to use this agent, of course, is the double coverage of strep itself in case the organism is resistant to clindamycin. So you'd use a beta-lactam agent such as Zosyn, meropenem, or imipenem if it were on formulary here, plus clindamycin, which has essentially a different way of killing the bacteria, inhibits protein synthesis versus inhibiting cell wall synthesis. And it also suppresses bacterial toxin production. So one of the most important things to think about clindamycin, we use this early on rather than for the whole duration. It's thought when we're sort of thinking about how long this hangs around in our body and has effects that this may have a longer post-antibiotic effect than beta-lactam, and does suppress the synthesis of penicillin binding protein. We use vancomycin for empiric MRSA coverage as we're establishing a diagnosis, and of course the gram-negative coverage of Zosyn or carbapenem, again, as empiric coverage before we know which microorganism is causing shock. Once we're able to confirm the diagnosis, we usually several days have passed. The added benefit of a broader beta-lactam is less relevant, and we typically narrow to clindamycin and penicillin G. If penicillin allergic, we could either use ceftriaxone or vancomycin or daptomycin if there's a beta-lactam class allergy. If the organism is clindamycin susceptible, we usually continue clindamycin for at least 2 to 3 days after patients have sort of emerged from septic shock. And if the organism is clindamycin resistant, we would use linezolid, which also has antitoxin production as well. Typically, we treat for at least 14 days after the last positive culture, surgical or blood culture. IVIG, I actually want to remind myself and you guys of the importance of using IVIG. There is likely a significant reduction in the 30-day mortality rate with use of IVIG if we use it early, so early on in the diagnosis to give IVIG. It's not particularly obvious that it is helpful after day 3 of a syndrome. We use hyperbaric oxygen therapy for soft tissue involvement. There is some interest in whether or not anti-TNF antibodies can help sort of dampen down the immune response as well in patients. And then finally, there's been much discussion. I would recommend offering post-exposure prophylaxis to close physical contacts of patients that usually would be penicillin or clindamycin or azithromycin in patients who are penicillin allergic. In particular, immunocompromised patients should be offered this. Staph toxic shock syndrome, historically, most of the time are associated with menstruation, though in non-menstruation cases, it can be associated with postpartum wounds, mastitis, burns, or post-surgical wounds. Most of the time, this is caused by MSSA, and I'm not really sure there's an identified explanation for that, though MRSA can also cause this as well. The diagnostic criteria is slightly different than it is with group A strep toxic shock syndrome. And one of the things I wanted to highlight is the difference in the rash. And I tried to give some photographs of the diffuse macular erythroderma that's often noted. The other main sort of presentation difference is the predominance of gastrointestinal symptoms. Often vomiting and diarrhea are associated with the presentation. In general, besides multi-organ system involvement, blood cultures will be positive for this organism and negative for other organisms which may cause similar syndrome, Rocky Mountain spotted fever, leptospirosis, and measles. So the treatment of Staph aureus toxic shock syndrome, the empiric therapy is the same as it is in group A strep toxic shock. And certainly once a diagnosis of staph as a causative agent is identified, we usually use oxacillin or nafcillin. Mostly out of clinical experience, we use this over cefazolin plus clindamycin, or vancomycin if the organism is MRSA. IVIG has been less well studied and therefore less associated with a positive effect, but is certainly something if we have available early on we would offer. I just wanted to provide a table to sort of illustrate the sort of classic differences between the two. Generally, patients are a little older for group A strep toxic shock. More women than men are associated with Staph aureus toxic shock. Local invasive disease is present in group A strep. Bacteremia is also much more common in group A strep. And the mortality rate for group A strep is much higher as well. One other organism just to mention for toxic shock syndrome, so Clostridium sordelli is something, and I actually have not ever seen this syndrome, but is toxic shock that can typically be associated in the postpartum, post-gynecologic, and post-obstetric procedure period. So this bacteria is part of the normal vaginal flora in about 10% of healthy women and can enter the uterus and enter the internal organs of the body that way. It's often found in our GI tract, as well as sewage and soil, and can, again, besides being associated with OB-GYN associated syndromes, can be associated in the IV drug use population, especially when exposed to black tar heroin, which has been associated with a contamination of this organism. And I mostly wanted to bring this up. It is actually incredibly deadly and incredibly precipitous syndrome where patients will develop a massive onset of edema, hemoconcentration, and notably, patients often will lack a fever in their presentation. So this in particular is something to consider in postpartum women and post-recent gynecologic procedures. Blood cultures are rarely positive, most likely because we are not as good as identifying anaerobic bacteria in the microbiology lab. We typically use zosyn and clindamycin and vancomycin if they have MRSA risk factors as empiric treatment. And surgery is really key to remove necrotic tissue. In general, this has been identified as the cause of death in 1 in 200 women of childbearing age. It's quite a deadly disease. Mortality rates can be as high as almost 70%. And typically, the syndrome moves fast, so one can develop symptom onset and proceed to death in 2 to 6 days. Moving on from necrotizing soft tissue infections, moving on from toxic shock, necrotizing soft tissue infections. So This in general is obviously rapidly progressive infections of generally the fascial or muscular planes or skin caused by bacteria, which create a fulminant tissue destruction, accompanied with signs of systemic shock and toxicity and a high risk of death. The overlap with toxic shock is that type 2 is identified as being caused by group A strep or other beta hemolytic strep, whereas type 1 is considered to be polymicrobial and usually more anaerobic predominant and occurs in more older or medically complex patients. As you can see, these photographs are actually quite similar to what I presented earlier, and this tight bullae formation and rapid progression are hallmarks and are key to the physical recognition of this. So typically, patient is healthy, has a penetrating trauma or skin breach. Sometimes they can be associated with diabetes in the setting of neuropathy or SGLT2 inhibitors, other immunosuppression, alcohol use, or recent pregnancy or childbirth. Key to this presentation is pain out of proportion on exam, the skin manifestations that I just mentioned and demonstrated. Typically, we make this diagnosis with CAT scans as well as clinical assessments, as well as this being a surgical diagnosis. So typically, we diagnose this at the time of surgery. Treatment is very similar to toxic shock syndrome, with actually surgery becoming sort of the key part of this. And mortality rates can be quite high, 21% in type 1 and 14 to 35% in type 2. Treat the shock, we debride necrotic tissue. And the one thing that I just wanted to highlight that I'm sure you guys are all aware of is the L-Rinek score, which I really appreciate being able to have at my disposal. So this is a score which involves the use of looking at patients' CRP, white count, hemoglobin, sodium, creatinine, and glucose. And essentially, it's providing me with a likelihood of necrotizing soft tissue infections in a patient. And I would say the main issue with the use of this score is the possibility of false negatives in this setting. And so generally, anyone who has a score, even it's supposed to be 6 or above, we're supposed to be concerned about necrotizing soft tissue infection. But I just want to highlight there actually have been patients with much lower scores who have this diagnosis as well. The higher the score, the more likely I am to be paging my surgical colleagues. Finally, the third syndrome I wanted to discuss are deep neck space infections. And I really like this topic in particular because the anatomy of the head and neck is so complex and often is why these infections can be so life-threatening and progressive. These are often rapid onset and rapid progression to life-threatening infections. Early recognition is key, but often challenging given the complexity of the anatomy in this area. Delay in diagnosis can risk the violation of natural fascial planes, which provide natural sort of barriers in different potential spaces in this aspect of the body. But once these resistances are overcome, infections can spread rapidly, particularly into the mediastinum. So the source is obviously usually up here, so usually our mouth, parotid glands, cervical lymph nodes, ears, and sinuses. It's thought that otogenic sources incidents are increasing, and probably because we're treating these conditions more with antibiotics, pharyngitis and tonsillitis sources are decreasing. Generally, this is seen more commonly in patients who have other underlying infections, diabetes, immunosuppression, alcohol use, and then IV drug use. This is a pretty rare condition. I think I've actually seen only 1 or 2 since joining MainMed about 2 years ago. And the thought is that this is generally a rare condition in that actually the anatomic issues that may put people at risk for this often get addressed by going to the dentist, treating ear infections, et cetera, before they spread to deep neck space infections. So this can present as syndromic abscess formation, cellulitis, or necrotizing fasciitis, with or without sepsis. And I wanted just to spend a little bit of time trying to go through the complexity of the anatomy of the head and neck, because this is often key in trying to understand where patients might be at risk for deeper infections. So when we're thinking about deep neck space infections, we often use the hyoid bone as sort of a border, which is here. So above the hyoid bone, we would consider peritonsillar, submandibular, parapharyngeal, masticator and temporal abscesses, buccal and parotid spaces. Then, and I'll get into this in a moment, there are three essentially columnar spaces which travel the entire course of the head and neck. And then below the hyoid bone, there are anterior visceral or pretracheal spaces. I included this, standard up-to-date picture mostly because I actually thought it was the best one to be able to try to demonstrate the complexity of this space. So there's the hyoid bone. I mentioned the spaces above the hyoid bone. These are the three columnar spaces that, as you can see, travel actually from the mouth and from the sinuses itself all the way down through to the mediastinum. And these three columnar spaces, as they're called, travel from the base of the skull to the mediastinum, the prevertebral space, so closest to the spinal cord and vertebrae, the danger zone, which is right next to the prevertebral space. It's called the danger zone because this is actually the most important, essentially, highway of contiguous spread between the neck and the chest, and then the retropharyngeal space in front of that. This is another way to kind of think about these spaces, and this, as you can imagine, is cut at the level almost essentially of the upper jaw. To me, what is so interesting, particularly in addition to the symmetry, is just how many spaces and sort of fascial planes we can see here, and how some of these violations can occur. I also just wanted to demonstrate the sagittal view of the retropharyngeal abscess as well, and also just how close to the vertebrae and then spinal cord it can get. Generally, all of these are mixed infections. About 5% are purely aerobic, with 25% with isolated anaerobes. I just thought it was really interesting. I was trying to read about the diversity in our oral cavity. People have many more diverse bacteria than other animals, but dogs and cats usually have more aggressive, foreign, so to speak, organisms, which are more likely to cause infections than human bites. So in general, viridin strep is the most predominant organism, followed by anaerobes, Staph aureus, and Pseudomonas, other strep species, and H. influenza as well. Empiric therapy often depends on the immune status of the host. We use CT scan to diagnose, and again, surgery is imperative for diagnosis and treatment. In general, treatment really depends on where the source is. If otodogenic and immunocompetent patients, we usually offer unison, or if allergic, ceftriaxone, or clindamycin and levofloxacin. If from an otogenic source, we would need to add anti-pseudomonal coverage, and if from a cynogenic source, MRSA coverage, as well as otodogenic coverage as well. If immunosuppressed, everybody gets coverage for Pseudomonas and MRSA. And I apologize for sort of rushing through the end, but I want to make sure that I'm giving enough time to Dr. Wood. But just to sort of review the concepts demonstrated here, we did discuss three different types of toxic shock syndrome, as well as necrotizing soft tissue infections and deep neck space infections as well. And I'll wrap up, and I think we'll probably end up taking questions at the end. I got so close. Wait, I don't think I'm sharing this yet. And then I can do. Great, thank you.
Okay, I'm going to take off my mask as well. So thank you, Dr. Woolston. That was a great overview of some scary infections, which I hate to see because I don't really like emergencies, which is why I went to infectious disease, so we can think about things and have time for that. So what I thought I would talk about is part of the time about mostly meningitis, encephalitis, and then some ID urgencies that don't really rise to the level of emergencies, but are stressful. So I thought it would be a good thing for this time of year. And for the CNS infections, I thought we could just start with a very generic case. This is someone that you're admitting who's healthy, 40s, has a headache, fever, neck stiffness. Of course, you're thinking about meningitis. You're thinking about getting an LP, but there are questions about whether you need to get a CT scan, what about steroids, which antibiotics, those sorts of things. So first question is, do you need to get a head CT before getting an LP? And this has kind of been in the ID lore for a while, but I think it's a good topic because it's something that, you have to decide right away about. And the reason that one might consider getting a CT before an LP is that you don't want to worry about cerebral herniation if there's a large mass lesion and you remove CSF that increases the intracranial pressure. But what they've found is that most patients really don't need a CAT scan before getting an LP. And really, one of the landmark studies was in 2001 in the New England Journal of Medicine, where they had 300 patients with meningitis. About 80% of them did have a CT before their LP, and in 24% of those who had that CT, the results were abnormal, and 5% had evidence of a mass effect. And so this is the, basically this shows what they found in people who had abnormal CTs, where really it was a very specific group of people who were immunocompromised, had a history of CNS disease, had a recent seizure, and then had basically focal neurologic symptoms or syndromes. And those people were the ones who were likely to have an abnormal CT. And so a group in Sweden had kind of national guidelines about bacterial meningitis. And in 2009, because of data like this, they said, well, let's take out impaired mental status as a contraindication to LP without a prior CT scan. And then in 2015, a group published in Clinical Infectious Diseases a look at, okay, what happens if you get rid of this need to get a CT in some additional people? Will that improve the outcomes? And so what they're really looking at is how quickly can you get antibiotics into people, and what were the outcomes if you were kind of speeding things up by not doing the CAT scan. And so what this shows here is basically this is like the post-intervention, so fewer CT scans. This is the more CT scan group. As you can see that if you weren't doing as many CTs, antibiotics happened earlier, and that if you were doing more CAT scans, antibiotics were delayed. And then importantly, that mortality was higher when antibiotics were delayed and there were more CAT scans, and that the neurologic sequelae were more in people who were getting CAT scans and had potentially a delay in getting antibiotics, as shown in the prior slide. And the sequelae are things like hearing loss, long-term neurologic effects, things like that. So these are some pretty old IDSA guidelines. I think they're under review, but I kind of doubt they're going to change all that much. They're from 2004, but I'll show this again when we get a little further down. But basically what this shows is that if you're thinking about bacterial meningitis, you ask yourself, do they have any of these concerns that might make you say, I need to get a CT scan? And if they don't, then you can proceed with the rest of your workup without getting one. So then the next question that comes up, which I think is really important, are whether you need to do steroids or no steroids before antibiotics. And the reason I bring this up particularly is a lot of times people will stop me in the hallway, they've already admitted the patient like yesterday, and then they're asking me like, hey, maybe I should give them dexamethasone. And sadly, that question needs to be answered like really at the time of admission when you're giving antibiotics or thinking about giving antibiotics. And so I think it's a good thing to go over. And basically, the idea for this is that bacterial meningitis is very inflammatory, and this is sort of the sequence of events where you have nasopharyngeal colonization leading to a local invasion, a localized bacteremia leading to meningeal invasion and bacterial replication. And from that, you have this very big inflammatory cascade with the immune system coming in, cytokine production, and then lots of inflammation and edema. And on the right side of the slide, you can see that the neurologic complications are kind of what I described before, which is impaired mental status, seizures, increased cerebral edema, focal neurologic deficits, et cetera. And there was a kind of some biologic plausibility for steroids, which were way back animal studies showing that hearing loss was related to these inflammatory changes from bacterial meningitis, and that dexamethasone would reduce CSF concentrations of cytokines, inflammation, and edema. And then there was a pretty small but randomized controlled trial in Vietnam with patients who have bacterial meningitis and received steroids. And what they found is that they had lower CSF opening pressures, lower productions of these inflammatory cytokines compared to patients who didn't. But one of the issues has been looking at these studies with dexamethasone. There have been quite a few of them that have been small, different groups of patients in different practice settings, different doses of dexamethasone for different periods of time. So it's been a little bit difficult to make conclusions over the years. In 2015, there was this Cochrane study that review that basically put everything together. And this whole series of patients, I think it's like 4,000 total, this was 2000 actually. So they looked at all these different studies saying, okay, do steroids for bacterial meningitis decrease mortality? And in this overall group, no. But when they looked at patients specifically with streptococcus pneumonia, yes, the mortality was decreased. And then same thing and even more so actually for severe hearing loss, when they put everyone together, so developing countries, developed countries, all different types of studies, patients with HIV, patients with TB possibly, didn't really seem to make a difference. But when they teased out developed countries, and especially patients who had strep pneumo, they showed steroids helped prevent severe hearing loss and other neurologic compromise. So basically the approach that we have now is in a developed country, you want to give someone steroids if you think they have known or suspected pneumococcal meningitis, which obviously when you're admitting a patient, you wouldn't necessarily have that information. But if you have a high suspicion for bacterial meningitis, strep pneumo certainly is high on the list of possibilities. If it turns out that it is based on the gram stain in the culture, then the dexamethasone is continued for 4 days. But if you find a different organism, then you can stop it. And the really key thing is it has to be started either before or right at the same time as antibiotics. And there actually was one small study where they showed an unfavorable outcome if you gave steroids after starting antibiotics. However, in developing countries, this benefit is not seen, probably because, unfortunately, there's a much higher mortality for bacterial meningitis in general because of things like delayed presentations, concurrent HIV, TB as a potential diagnosis, and other things. So these are back to the 2004 IDSA practice guidelines, where you can see basically you're coming down these different pathways with whether or not you need to get a CAT scan, and then starting dexamethasone and empiric antibiotics right at the same time. If you think the little B goes with if you think this is potentially strep pneumo. So you have this patient you're admitting to remind you that you're thinking bacterial or thinking meningitis. And basically, when you're kind of trying to think about, okay, which antibiotics should I be starting? What should I be thinking about? You need to have a differential diagnosis. And this is, just the basic table that you can always look up, but I think it's nice to review, which, to remind you, so bacterial infections, you're going to see mostly polys, viral infections, or fungus, or TB, or kind of non-infectious things, you'll see mostly lymphocytes. And then with bacterial infections, high protein, low glucose, things like TB and fungal infections, high protein and low glucose. But with viral infections, it could be normal protein and normal glucose. So those are tend to be kind of bland. And then just a couple definitions to help you also characterize, what does this patient have, which we'll get into the symptoms of in a second. But basically, encephalitis is inflammation of the brain parenchyma, the brain itself. Meningitis is inflammation of kind of the covering of the brain, so arachnoid membrane, et cetera, and the spinal fluid. And then sometimes we have the dreaded aseptic meningitis, which is you're doing your best, but basically nothing grew. You're pretty sure this person has meningitis, and that's a whole different topic for another day. But lots of things can cause that, like viruses, medications, previous antibiotics that sterilize the cultures. And then there is meningoencephalitis, where it's kind of a combination of all these things. And the way you can differentiate these clinically is that encephalitis is really about altered mental status. So there can be a viral prodrome, kind of depending on what the cause of it is, so fever, malaise, myalgias, sometimes like nausea and vomiting, depending on what the virus that caused it was, and then altered mental status, whereas meningitis is like the patient that we are kind of admitting in this scenario who has more classic fever, headache, stiff neck, photophobia. So once you're, thinking, okay, I think this is probably meningitis based on the LP and their symptoms, that kind of thing, then you can decide, okay, what is the most likely organism here based on this person's age and risk factors. And this was from the New England Journal of Medicine, looking at 1,600 cases of bacterial meningitis, and most of us are taking care of adults, so I'll just focus on that. But as you can see here, the vast majority is this orange line, which is Streptococcus pneumonia. And then as people get older, there's more of this bluish line, so that's Listeria. So those cases can increase in older adults. And then Group B strep, Haemophilus, and Neisseria meningis are the other ones. But really, the majority of adult cases are strep pneumo. As opposed to encephalitis, which can be fairly frustrating because much of the time you don't get a diagnosis. So this was National Hospital Discharge Survey data, which is always like tons of cases. So in this case, it was 186,000 discharge diagnoses, basically. And what they found or didn't find was that 60% of the time this was unexplained. And then viruses were responsible, like they were able to find a virus in 16% of the time. So these can be really challenging cases. So as you're admitting the patient, you can think about this. This is, again, from the IDSA guidelines, but I'm sure they have something similar and up to date. What are the risk factors as far as age? And then is there anything else that is making them more at risk for any particular organisms? And the big ones are, for most people coming in with a kind of like community-acquired meningitis, you want to start with vancomycin and a third-generation cephalosporin like ceftriaxone. So vancomycin and ceftriaxone, you're good. Over the age of 50, the risk for Listeria increases, as we showed there, so you would add ampicillin. And then if there's any kind of like manipulation, like either penetrating trauma or neurosurgical patient, then the gram negatives are more likely, so you want to change the ceftriaxone to something more aggressive like cefepime or meropenem. And just a little tip that Zosyn does not get into the spinal fluid very well, so don't choose that one, but most other things do. And then I'll just throw this in there because it's summertime and these things come up and they're like fun and not fun at the same time. If you find it, it's fun. If you are looking for it and can't, then it's not that fun. But basically, there are many arboviruses, which are arthropod-borne viruses, so like mosquitoes and ticks and things like that. And you can see there are all these different like regional differences. The big ones, we have kind of big three that are around here, but in Maine, it's so clean and pure, we really don't have too much of this happening, but there's triple E, so Eastern equine encephalitis, quite rare. As you can see, it tends to occur on the East Coast, and it can occur in these kind of outbreak settings with a lot of horses involved and things like that. In Maine, I think we've had a total of 2 cases over the years, and it's very notable because it's a very rapidly progressive infection with a high mortality rate. And so people come in with high fevers and vomiting, and then there very quickly becomes brainstem involvement, convulsions, et cetera, and there's no treatment for it. As opposed to West Nile virus, which is fairly common, although not really that common around here. And this is something that started on the East Coast back in 1999 and kind of has like marched its way across the country, as you can see, as these are the higher density numbers over here. Also mosquito-borne, and it can cause a pretty like wide range of symptoms. So the vast majority of people will have no symptoms. About 20% of people who get infected will have basically West Nile fever, and then only about 1 out of 150 or 250 have neuroinvasive disease. Some people can have a rash, and that's kind of more consistent with the West Nile fever. And then if there's neuroinvasive disease, that's encephalitis, meningitis, there can be some focal neurologic findings, and this tends to occur more in older individuals or the immunocompromised. I think we've had about 2 cases in Maine, and the last one was 2015, so it's been a little while. Both of these infections tend to occur like August into September, so it is kind of the time of year, which is why I bring it up. And then finally, I meant to mention, I have no gross pictures, but I have one cute picture. So, so this is a woodchuck, and Powassan is transmitted by the woodchuck tick, and it's closely related to the deer tick virus, which is transmitted by deer ticks, of course, and a little bit different from the mosquito-borne ones because it's a tick, but kind of similar syndromes where someone will have a viral prodrome of fever and sore throat, and then the actual encephalitis can occur weeks to months later. And this one can have a pretty devastating neurologic deficits afterwards. The mortality rate is 10 to 15%, but there can be long-term neurologic sequelae. And the other kind of interesting thing about this one is we always counsel patients a tick bite, it takes about 48 hours for the Lyme disease to be transmitted. So what I don't like to mention is that it's 15 minutes of transmission potentially for this organism, but it's really rare. So unlikely that's going to happen. And the way that you would help, hopefully this may help you kind of figure these things out, is there's a CSF test order set that gives you all these different cell count orders for the different tubes and stuff. But the other nice thing about it is that if you are thinking okay, this might be something weird, we need to start getting into additional testing, we have these different tiered testings for people who are maybe immunocompromised, or you're thinking, oh, this is a second spinal tap because the first one, we didn't grow anything, so now we need to get into some viral PCRs and things like that. The other thing is that this has this CDC information up here, and one nice thing, you can order those EEE and West Nile things from the Mayo test catalog, is that what to say? But the other thing is the Maine CDC has really nice arbovirus testing, and you do need to fill out a form, which is one extra step I realize. But what they can do is what they know is what's circulating. So they may know that there's Jamestown Canyon virus in New Hampshire, and so therefore we should test for it in this particular patient who has compatible symptoms, which, most of us aren't going to necessarily say oh, let's look for that particular thing, or lacrosse virus or something like that. So I definitely encourage you if you can. And then the Nordex will send the spinal fluid there, but it takes a little coordination. So that is basically the case. So to review, you have this healthy person coming in, you decide to perform an LP on her. You don't need to do a CAT scan first in this particular patient because she had no risk factors. And then when you started antibiotics on her, most likely you would do ceftriaxone and vancomycin, and probably a good idea to do steroids because the likelihood of strep pneumo is probably 70%-ish in her. So hopefully that's helpful. And then I thought I would throw in some ID urgencies to just things that, like I said, I don't really love emergencies because it's more fun for me to think. I know some of you may be going to critical care, et cetera, but I like to, which is a very cognitive field as well. But I like to think more slowly. So here are some things that may come up when you're just kind of minding your own business. And basically, one is say it's Friday night. Bad things happen on call on Friday nights because you're in that big black hole until Monday morning. And I'm on call this Friday, so I'm sure bad things will happen. But so you're Friday night and you're looking through your results, and there's a positive quantiferin TB gold, and you're like, what is this doing here? What am I supposed to do? So the first thing to do is figure out why was this ordered. And most of the stuff you can kind of figure out from just looking at the chart initially. So maybe it's just a screening test because someone's going off to college, or maybe somebody was recently in the clinic and they had a cough and hemoptysis. Probably that's not the order of events that would be, but how symptomatic is this person? Do they have any risk factors for latent or active TB? So is it someone that seems like they've been pretty much in Maine, or have they come from an endemic area or had a potential exposure? And then where are they now? And that's when you probably need to start doing some digging. So what you want to do is find out how are they feeling. If this was done kind of more for, hey, I think this person might have TB, then find out how the person is feeling. If they're asymptomatic, then it's probably latent TB at the most, and you can obtain chest imaging, refer them to the TB clinic. If they're symptomatic, like this has been going on, has had a cough, and they have a stable housing situation, then they can actually just stay home, because what you don't want is them entering the community and potentially infecting people if they have an active TB case. If they're homeless, then you don't want them to be out in the community, obviously. In the state, TB consultants can actually help get a hotel room for this person, and so that they can be safely out of the community and more testing and evaluation can be done. Of course, if they're sick enough to be in the hospital, that's another matter, but many people can actually kind of stay out of the hospital while this evaluation is happening and hopefully avoid potentially making other people sick. And there, you can easily Google, like, the way I found this number was Maine CDC TB. So you can easily Google that. I threw it in here, not that anyone's going to write that down, but the public health nurses, which is what PHN stands for, they will go to either the person's house or this hotel room to get sputum for PCR and AFB. And the TB clinic is also a good resource if you're having to deal with all this. Similarly, you're admitting someone with pneumonia, and there's a CAT scan that's done for whatever reason, and it shows a capillary lung lesion. And they're like, oh, great, what is this? What is this mess? So first question is, you know, and you're seeing the patient, so you can get a lot of this information as you're seeing them. What are their risk factors for TB or any other infection? So have they had travel, contacts with TB, recently incarcerated ever, really? Have they lived in an endemic area, homelessness? And is there an obvious diagnosis that really explains this capillary lesion, like septic pulmonary emboli, which really doesn't necessarily look like this, but sometimes they can have these sort of cavitary appearances. But if the TB is on the differential, which, you know, we should all have a high index of suspicion for that, there is a TB algorithm order set that really helps you go through the testing, and it's really comprehensive. It has like testing, treatment, how to discharge a person, all that kind of stuff. But what it does have nicely are all the sputum tests that you need to order, which are 3. They have to be 8 hours apart, and one has to be first thing in the morning, which is all a pain to order, but it's in the order set. So you don't have to like do all that. And then while you're waiting for all this stuff to come back, which unfortunately takes a few days, you can start thinking about alternative diagnoses, like maybe this person has really an abscess and they're getting better on Zosyn, and so it's probably not TB anyway. Of course, if it's TB positive, AFB positive, call us. But if it's AFB negative and there's really no alternative diagnosis and they're not really getting any better, TB is still in the differential, and you can definitely still call us because sputum testing is not 100% sensitive. And this is just, I think, a basic up-to-date slide showing that there's a huge list of things that can cause capillary lung lesions. And then there's this really, I shouldn't say fun, but exciting thing that is happening right now that we could ignore COVID a little bit, but is this kind of this multi-state investigation of Burkholderia pseudomallei, which is also called melioidosis, which is endemic in Southeast Asia. And there are these 4 patients who have never traveled there, have never met each other, and they have genetically linked cases by the organism. The organism's genetically linked, so it's kind of cool. So more to come on that. I'm much more interested in 4 cases of bacteria than hundreds of thousands of cases of COVID, so sadly. All right, a couple more quick things. So you're called in the middle of the night, you're covering on night flu, and somebody has positive blood cultures. And so first thing, of course, the nurse will call you and say, oh, the person's blood cultures are positive. You look up an EPIC. You want to know, is this gram positive or gram negative? And I'll explain why in a minute. And then big question is, why were they drawn? Is this person sick? Are they having fevers? Or is this just done because somebody thought it was, you know, they're coming in anyway, I'll just get blood cultures for some reason. Like sometimes it's not a great reason, in other words. And so what you need to do is start antibiotics, but be thoughtful about it. So if this is 1 out of 2 blood cultures that's positive, you're looking at this patient real quick and you're saying, like, it doesn't even seem like they're all that sick. Maybe you could get another set of blood cultures first and then start the antibiotics, because there's a chance that that's a contaminant. Await the rapid ID, which I'll mention in just a second. And if it's a gram negative, you really don't need to repeat the blood cultures because those clear quickly, and where there's no really sequelae of having, it's unlikely that they're going to remain positive. You don't always need an echo, so you can kind of wait until you get some more data before you kind of instinctively order that, because not every organism needs an echo. And then we really appreciate being involved if it's Staph aureus yeast, Staph lugdunensis, which is a type of coagulase negative staph that's really aggressive, or Enterococcus. But we're definitely happy to discuss any other bacteremia types of cases in consult as needed. This is the rapid ID that, from talking to a couple learners earlier this year, I realized not everybody knows what it is, but basically the traditional blood culture timeline is that someone has blood cultures drawn, it becomes positive, so a gram stain is performed, and then it takes 24 to 72 hours to do standard susceptibility testing. That's what the AST stands for, antimicrobial susceptibility testing. But we have these rapid diagnostics now, so with a gram positive, after the gram stain becomes positive, in 2 to 3 hours, we'll know whether it's MSSA, MRSA, Enterococcus versus VRE, different types of strep. You still have to get the full susceptibilities in a day or two, but at least you can get some early information. And then with gram negatives, again, once the gram stain or the bottle turns positive and it's gram stained, you can get a rapid ID in a couple of hours, and you can get full susceptibility testing in 6 to 7 hours. So it's really great because it helps you de-escalate antibiotics much more quickly. And this is just a quick plug to say that this looked at a group of people who are getting follow-up blood cultures, and I'm not going to go into this in the interest of time, but basically follow-up blood cultures for gram negatives didn't really make a difference other than potentially adding to the length of hospital stay, antibiotic cost, exposures to antibiotics, that kind of thing. So unlikely to change management for most people. And then another Friday night thing, which is, I'm like totally like ruining my Friday night by saying all these things, but someone has a positive urine culture. So you're called by the micro lab, or the patient calls and says, I saw this in my chart. And so, because that happens now. And so one thing you need to know was there a UA? That's a really important piece of information. People really shouldn't be getting urine cultures without UAs, but it's definitely possible to order that in Epic that way. So you've got to be cautious because you want to know like how inflammatory is this situation. And then why was this done? Was it asymptomatic? Was it the forbidden test to cure, which you should not do at the end of a UTI treatment? Did they just happen to be passing through urology and they were like, let's get some urine, that kind of thing? And so, you know, you could probably figure out a lot of that from the chart. And then if they're asymptomatic and not pregnant, you don't need to treat this. If they're symptomatic, then yes, of course, you want to start treatment. And if this has been kind of a recurring theme, you can look at past cultures and past treatments and use that to guide your decision. And then if it's not recurring, you're kind of saying, oh, you have a UTI, let's treat it. The two big things we usually start with would be nitrofurantoin or Bactrim. Those are the top choices. Fosfomycin is kind of second tier because it doesn't work quite as well. It's also really expensive and not that easy for patients to get. So I would start with one of these guys. And then we try to avoid starting with something like Cipro. I know it works well, but it's got a lot of chances for side effects and increasing resistance. So the other nitrofurantoin and Bactrim are good things to start with. And then final thing is, this is not for someone necessarily with an epidural abscess, but someone comes in with back pain and they get an MRI and it shows possible vertebral osteo. And so big question is, how sick is this person? Like, are they having fevers? Is there any concern for neurologic compromise? But if their big complaint is back pain and they're otherwise not having any signs of infection, you can draw blood cultures, consult someone, IR, neurosurgery for biopsy, and then consider holding antibiotics if they're really not that sick, because that will really increase your yield of getting a good culture. The blood cultures are positive like 50% of the time, but you know, we actually don't love sending people out on vancomycin and zosine for 6 weeks, so it's much better if we can like target an organism. And this is true for osteomyelitis otherwise. So if people come in with like a diabetic foot ulcer that's pretty gross looking, but not necessarily all that sick, you can probably wait and see what your surgical colleagues might be doing with it. And then questions we can take some now, but always, we love talking about cases, so feel free to call us anytime.
Why don't we start with questions in the live audience, and Dr. Woolston, you have a patient you have to go to. Any questions for Dr. Woolston first, and she has a patient she has to go to see, and then people on Zoom, if they want to add questions in the chat, go ahead. I don't see any. Oh, no.
Just Christina, yeah.
Any questions?
So the question was, how do you approach a possible UTI in someone who has altered mental status? Those are hard, basically. I mean, I think we probably end up treating those a fair amount of time, especially if there's fever, you know, have an alternative source of their altered mental status, and, you know, you're kind of looking at the risk benefit of some antibiotics versus, okay, this person's really not doing well, what else can we do here? So I think those are tough. I think if it's, just altered mental status and no other signs of infection, those are the ones that we try to sort of say, well, try to see if there's anything else that's causing this. So the question is, what do you do if the UA is positive, the patient has symptoms, and our culture didn't grow anything? Usually I pick a generic antibiotic, and then I say, if you're still having symptoms in a few days, we can recollect and kind of go from there. And I'd say the majority of times people seem to get better, or it's like that mixed flora situation, yeah. Sophie has a question. I think it depends on the risk factors and, sorry, I was doing so well. So Sophie's question was, how do you manage somebody who has a cavitary lung lesion and do they need precautions? And what I was saying was that I think that depends on the risk factors, depends on the chances of alternative diagnosis. But if you're thinking there's a chance of TB, then unfortunately, yes, you need to move them to a precaution room. If you think like, oh no, we know what this is, like they have cancer and this is a post-obstructive pneumonia or something like that, then you probably don't. And there's no risk factor for exposure. That's how I would approach it. Those are tough. I don't know if they'll be able to hear you. I would say if it's like 3 o'clock in the morning, my general approach would be absolutely put them in airborne until the next morning, into the light of day. I would say there's little harm in putting people in airborne precautions in that setting. It's usually a rooming issue, which we would have to absorb as a problem health system wise. But if you're worried, I would definitely put them in precautions, kind of like COVID, obviously. Yeah, so the question is, when in toxic shock syndrome would we discontinue the adjunctive, usually clindamycin or occasionally if clindamycin resistant linezolid? And it's exactly as you said, once they're out of shock, but actually more specifically, patient's shock is resolved plus 2 days. I don't think there's necessarily a magic number, but it's honestly once the dust is settled. And I think that the issue is more just the development of side effects usually associated with clindamycin, and so there's not necessarily a harm in over treatment except for side effects. I would say the follow-up was for antitoxin agents such as clindamycin for necrotizing soft tissue infection. When would you discontinue clindamycin then? And it would be similar. Patient has had source control, is out of septic shock plus a couple days. And it's more you just don't want to undertreat. That's a great question. So the question is the use of clindamycin as an adjunctive therapy in toxic shock. Is it predominant or is it related to its susceptibility? I would say it's mixed. So it probably has some antitoxin effect, even if it's resistant, but I would not be particularly confident that it's going to be that helpful in that case. I think the issue with that is we don't know when we're starting it. It'll usually take some time before we're able to identify the blood cultures, organism, and susceptibility. So this is for like toxic shock. So the question is about post-exposure prophylaxis, the use of post-exposure prophylaxis. So I would say that once the diagnosis has been made, these patients are often critically ill. So it's either asking them or helping them identify people in whom they've
been touching, so physically close to. There are actually some articles like that go into great detail about who they've been kissing and hugging, but sort of close physical contacts of patients. There's a debate on whether or not it's necessary, and my policy in these particular sort of concepts in infectious diseases, this is a serious thing, and so for things that are debated, like IVIG, and in this case, post-exposure prophylaxis, I usually do give to people who they live with, particularly in whom are susceptible, so immunosuppressed or old, or very young, excuse me. And usually it's, and I apologize, I can't recall the duration, but something like a week of penicillin. Do we know it's necessary? No.
Well, I don't see any questions on Zoom, so I think we'll wrap it up. So thank you very much. A round of applause for both speakers. That was great, and thank you